Detection of occupational cholangiocarcinoma in a high-risk patient under intensive surveillance. A case study. Presentation by Aishwarya Jagtap, Group 1E, 6th course. Background. Occupational cholangiocarcinoma is associated with exposure to organic solvents such as dichloromethane and 1,2-dichloropropane. Case presentation. A 43-year-old man working at a company that had been exposed to organic solvents for 15 years was introduced to the hospital with thickening of the gallbladder wall observed on abdominal ultrasonography during a routine medical checkup. He had no significant medical history. Initial dynamic CT revealed gallbladder wall thickening suggestive of chronic cholecystitis with no lesions on liver. The patient continued regular medical checkups due to history of exposure to carcinogenic dyes. His regular checkup at 48 years revealed a mild elevation of the serum gamma GTP level, which was 82 units per liter and remained elevated between 80 and 100 units per liter. Blood test results, and here we can see at age 48 the gamma GTP levels have increased and have kept increasing since then to the age of 53. Also, his liver function tests were normal and he had a child pug score of 5A and liver damage level A. There was no evidence of HBV or HCV infection, and the tumor markers were within normal range with CEA at 1.6 ng per ml and CA19-9 antigen at 36.1 units per liter. This is the image of temporal changes in abdominal CT and MRI findings. In figure A, B, and C, we can see that there is absence of abnormalities in the intrahepatic bile ducts during initial examination, and in images D, E, F, and G, we can see that there is dilation in section B8 of the bile duct. In figure H, we can see that they have done diffusion weighted imaging and there is an area small area of high signal intensity observed. And in figure I, J, K, and L, we can see that it is the preoperative imaging revealing a tumor with ring enhancement at the root of B8. And corresponding to that area and the high signal intensity on DWI imaging has increased in size in figure M. Instrumental diagnostics. MRCP at 48 years old revealed thickening of gallbladder wall and chronic cholecystitis without dilatation of the bile duct. Dilatation of B8 was observed on dynamic CT and MRCP performed at 51 years of age. Diffusion weighted imaging revealed a small area of high signal intensity corresponding to the center of dilated bile duct in MRCP, as we saw in the previous figure. MRCP at 53 years old revealed further dilation of B8 and enlargement of the high signal intensity area on diffusion weighted imaging at the root of B8. Abdominal dynamic CT revealed a nodule with ring enhancement in the same area. Drip infusion cholecystocholangiography revealed stenosis of the roots of B8 and intermediate B2. Development of malignancy was suspected and diagnosis of intrahepatic cholangiocarcinoma at roots B8 stage T1A N0M0 was established. Surgical treatment was done for this patient. Right anterior sectionectomy to preserve the remaining liver volume to ensure sufficient distance from the tumor was performed due to the high risk of developing cholangiocarcinoma in B2 region in the future. The operation time was 502 minutes and the blood loss was 1175 ml without any transfusion. The patient was discharged on the seventh post-operative day without any complications. After surgery, post-operative adjuvant chemotherapy with S1 monotherapy was administered for 6 months. The patient is currently on regular follow-up every 2 to 3 months with performance of blood tests including gamma GTP, CEA and CA19-9 and MDCT alternating with MRI and sometimes additional abdominal ultrasonography. 2 months post-operatively, the gamma GTP value decreased and remained within normal levels thereafter. 8 months post-operatively, the patient presented no signs of recurrence. Macroscopic findings. Here we can see that the red circle shows invasive carcinoma and the white arrow it shows protrusion of tumor in the dilated bile duct in the section B8. So the macroscopic findings were a well demarcated solitary tumor extending to the dilated bile duct was found in the root of B8. The cut surface of the tumor was whitish with irregular well defined borders suggestive of mass forming cholangiocarcinoma. The bile duct walls in B8 peripheral to the tumor were dilated and thickened with tethering observed on the liver surface. In this figure, we can see the microscopic findings. In figure A, we can see that there is adenocarcinoma with papillary glandular ductal structures at the root of B8. In figure B, we can see tethering on the liver surface owing to inflammation around bile ducts with biliary intranodal intraepithelial neoplasia. In figure C, we can see biliary intraepithelial neoplasia at the peripheral side of tumor in B8. In figure D, we can see strong inflammatory response with lymphocytic infiltration around the main tumor and biliary intraepithelial neoplasia. And we can see dysplasia in B5 in figure E. So in summary, we can say that in the root of B8, an adenocarcinoma with a papillary glandular ductal structure was observed in figure 4A. In figure in figure 4B, immunohistochemistry showed positivity for S100P, a marker of malignant transformation, leading to the diagnosis of well differentiated intrahepatic cholangiocarcinoma of large duct type. Biliary intraepithelial neoplasia with disruption of cell polarity was observed in the dilated peripheral B8 distal to the tumor in figure 4C, and dysplasia was noted in B5 which converged with the right anterior sectional bile duct central to the tumor in figure 4E. Notably, a strong inflammatory response with lymphocytic filtration was observed around the main tumor and biliary intraepithelial neoplasia in B8 in figures B and D, but it was not found around the dysplasia in B5. These are the pathological findings identified with immunological staining. In figure A, we can see CD8 positive T cell infiltration in the tumor stroma. In figure B, we can see CD163 positive macrophage infiltration in the tumor stroma. In figure C, we can see PD1 positive lymphocytes in the tumor stroma. Figure D shows CTLA4 positive lymphocytes in the tumor stroma. And figure E is enhanced PDL1 expression in stromal cells of the invasive carcinoma. F gamma H2AX expression detected at various levels in the bile ducts irrespective of cancerous and non-cancerous sites. Discussion. In this case, intrahepatic bile duct dilatation appeared first, followed by tumor shadow consistent with previous reports. Prior to the detection of the mass lesion, MRI revealed a small area of hyperintensity on diffusion weighted imaging. Pathological examination revealed diffuse chronic bile duct damage, precancerous lesions, early stage cancer, and cholangiocarcinoma. This patient was diagnosed with cholangiocarcinoma 16 years after the last exposure to DCM and DCP, which are carcinogenic dyes. The formation of a tumor at the root of B8 likely induces obstructive cholangitis, consequently leading to biliary intraepithelial neoplasia changes owing to inflammation. Given the widespread presence of dysplasia in B5, which indicates a significant risk of progression to cholangiocarcinoma in all remaining bile ducts, rigorous follow up is paramount to detect recurrence early. Restricting the surgical approach to anterior sectionectomy also provides flexibility for subsequent lateral sectionectomy when de novo tumor emerges at the B2 constriction site, as indicated by the appearance of hyperintensity in on DWI in MRI. Conclusion: this was a case of occupational cholangiocarcinoma in which early diagnosis and therapeutic intervention were possible through effective screening. Early detection of occupational cholangiocarcinoma in workers with a history of exposure to organic solvents may be provided through a combination of ultrasound and clinical tests, including gamma GTP, AST, ALT, CA19-9, and CEA. In this case, only gamma GTP was elevated, whereas the tumor marker CEA and CA19-9 did not increase. Continuous screening is extremely important to avoid underdiagnosis, particularly in patients at a risk of developing this disease.